Okay, so your facilitators today are myself, Julie Seward. I'm a member of Cherokee Nation. I'm also the Oral Health Programs Manager at Southern Plains Tribal Health Board. And joining me is Alexandria Holt. She's the Public Health Specialist at the Southern Plains Tribal Health Board and works with me on known activities. I'm really excited about our panelists today. We've got Dr. Mary Willard. She's the clinical site director at the Alaska Dental Therapy Program at the Illicellewaet College. We've got Dr. Miranda Davis. She's a native dental therapy project director at the Northwest Portland Area Indian Health Board. And Kim Russell, she's executive director at the Arizona Advisory Council on Indian Healthcare, excuse me. And Dr. Michelle Dennison-Ferris, she's the health policy liaison at the Oklahoma City Indian Clinic. And their photos are clockwise from top left. Okay, so like I mentioned earlier, this is the third and final webinar in our series. I know some of you have joined us for the first two. For those of you that have not, or a review for those that have, just a quick recap of what we kind of talked about on our first two webinars before we get into these discussions with our panelists. The first webinar that we held was Dental Therapy, the Basics, which is pretty self-explanatory. We heard from Brett Weber from the National Indian Health Board and Tara Bianchi from Community Catalyst. And we really just talked about the basics of dental therapy, an overview of what it is and what it looks like in other states. We talked about the need for dental therapy to address a systemic problem. And we discussed the evidence of the safety and efficacy of dental therapists, and also what dental therapists look like under the community health aid program. So Brett talked a little bit about that. So our second webinar, we heard from Dr. Christopher Bailey. He's the Chief Dental Officer, the Dental Director at Choctaw Nation, and Roz Ferry. She is a practicing dental therapist from Port Gamble Scollum Tribe in Washington State. And we touched on dental therapy advocacy, outreach, and other activities that are happening throughout Choctaw Nation, which is the southeastern part of Oklahoma, for those of you that are not familiar. We also talked about how dental therapists are expanding oral health services to rural tribal families. And we had a storytelling from Roz, which was fantastic. She had a very impactful, powerful story about her personal journey and experience and how she became a dental therapist and what it means to her and her tribal community. These two webinars that they are on our webpage for you to go back and view if you so choose. Okay, so I am going to stop sharing my screen here and we're going to get into our panelists. So I think I saw, yeah, Dr. Willard is here. So we're going to get started with Dr. Willard. She graduated from the Ohio State University College of Dentistry in 1994, and she completed a 2-year general practice residency at the Carolinas Medical Center in Charlotte, North Carolina in 1996. She joined the U.S. Public Health Service in August of 1996 and is currently a captain in the commissioned corps stationed at the Alaska Native Tribal Health Consortium, excuse me. She's a clinical site director for the Alaska Dental Therapy Educational Program at Illicellewaet College. She has worked in American Indian Alaska Native Dental programs since 1996, including having experience as a clinician administrator, supervising dental health aid therapists, and working in remote Navajo and Alaska Native communities. So with that, I want to hand it over to Dr. Willard.
Hi there, thank you. Sorry, my computer just told me it wanted to restart. I'm like, no, not right now. So good morning, everyone. Glad we could all get together this morning. I am going to talk a little bit about dental therapy education, or DHET education, which is something I've been doing for the last 13 years. Are you going to do the slides, Julie?
I can if you need me to, Dr. Willard.
Oh, well, I can share my, I guess. Well, yeah, if you can, that would be helpful.
Okay.
I'm not at my regular computer, and so like Julie said, I have been working with dental health aid therapists for many years, and with dental health aides in general since about 2000 up here in Alaska. It's been a wonderful experience. I'm really excited that other regions of the US are now going to be able to experience working with dental health aides in their tribal health systems. It's been a great asset for us. As far as, so there are more than one type of dental health aides that you could utilize out there. DHAT is the most notorious dental health aid that we have in the system. We also have primary dental health aides, which are oral health educators. We have expanded function dental health aides, which is self-explanatory, and a dental health aid hygienist as well. So, but we're talking about the dental health aid therapist now. We can go ahead and next slide. Just thought I'd make you all jealous. This is Denali, the highest mountain on the continent, and from base to summit, it's a mile higher than it's a mile higher than Mount Everest. So it's a pretty dramatic thing, and part of why I love it up here in Alaska. Next slide, please. The Commission on Dental Accreditation is the only accrediting body that accredits dental education programs in the US. Back in 2015, they approved dental therapy educational standards. Those standards were developed utilizing a lot of the standards directly from dental school standards and hygiene school standards. So those are comparable in depth and rigor to the other types of dental education programs across the US. And I have to say they were very thorough, and I think very well written. Next slide, please. In the Code of Standards, there's no degree specified for a dental therapist. So as long as the program is at least equivalent to 3 academic years, then that's long enough for CODA to be satisfied with the program. Next slide, please. The impact of these CODA national standards nationally is that there's one national and streamlined standard, which will help hopefully in the future ensure that we have dental therapists that look like each other from state to state. Currently, as these dental therapy legislation has been passed, the educational requirements have been very variable. And so it's good to have this standard so we can all, when we're talking about dental therapists, we are basically talking about the same thing nationally from state to state. It also allows for portability, meaning that if you are a dental therapist that graduates from a CODA accredited program in one state, you can more easily move to another state to practice, as long as the legislation is written to allow for any graduation from any CODA accredited program. It also allows for students to be eligible for financial aid, which makes it much more easy for students to attend dental therapy education programs. It sort of legitimizes dental therapy programs and the profession to the rest of the world, although I'll have to say there was no need to legitimize it to those of us that have been working with dental therapists over the years. It speaks for itself. States can simply define dental therapists as a graduate of a CODA accredited program. Prior to CODA accreditation, their states had to sort of define what they expected for the education process. And that's why things got so different from state to state as we went along. Next slide, please. So Illisavic College is where our Alaska Dental Therapy Educational Program, or ADTEP as we say for short, that program is located or housed academically. That college is in Alaska. Of course in Alaska, but also Barrow, or what was formerly known as Barrow, now known as Utqiagvik, Alaska. And we are the only CODA accredited dental therapy program in the US. We got our accreditation in August of 2020 after a few years of working towards that. And so we're really excited about having that distinction, and it helps to legitimize our program, you might say, as well, although our track record has been exceptional, and we knew we were doing some good stuff even before CODA came along and said, yeah, you guys are making it, and you're up to the same standards as other dental education programs. Next slide, please. So how we do dental therapy education here in Alaska is you can find out what our curriculum is like pretty much by looking at this publication from Community Catalyst called A Sample Dental Therapy Curriculum for Community Colleges. And that a lot of dental therapy educators or dental educators got together and put this curriculum together. It's pretty much our curriculum with just a few little caveats, but we do our education in 2 calendar years for our dental therapist. Those 2 calendar years are packed full, and they're equivalent to 3 academic years. So there's 7 semesters within those 2 calendar years. And the way we teach everything we need to teach our therapist in that amount of time is we spend our time working with things they need to know, and we don't put a lot of stuff that's just nice to know in there. So the difference, like in dental school, I might have studied the full cadaver in my anatomy class, and in our dental therapy class, we're going to study the head and neck region very, very heavily. And we're not going to need to know the bones of the hands and feet and things like that. But we do know the body system, so we understand how the oral cavity and tissues interact with the rest of the body. But we don't need to know some of the specifics of diseases and things that a dentist needs to know because we have a dentist supervisor. So what we teach our therapist is to go through the health history really carefully, ask the right questions, and if there are things that come up that might need further understanding of the body and the health and things like that, then we would that would be something that the therapist would then consult with their supervising dentist about. So, so they get to know things that are really important and will help them be a very competent and effective dental therapy provider. All right. Next slide, please. So as I said, it is a packed curriculum. In those 2 calendar years, the students are in class basically Monday through Friday, 8 to 5 for 2 years. So it's very different than some of the colleges you might have gone to in the past. And they get over 2,000 hours of instruction during this process. When they're learning procedures that are similar to a dentist. So if they're doing a class 2 restoration and prep, they are learning out of dental textbooks. And we're teaching them the same standards that you would teach at a dental school for those same procedures. We actually have dental school instructors that come and teach those parts of our curriculum. So they use the same teaching materials as they use in the dental schools where they work. So it's pretty intensive course. It's challenging. You know, we really put these students to the test, you might say. They basically don't get to have much of a life for these 2 years. They need to really focus while they're in school on being in school. We're clear about attendance. It's important and it's part of every grade. So missing classes is not something that will help you get through this program at all. And actually our attendance policy is that there are no excused absences in our program, period. Just doesn't, nothing gets excused. You have to complete all and make up anything that you might miss. And so, you know, over the 2 calendar years or the 3 academic year equivalents, they learn quite a bit of dentistry. Next slide. So, and I'm assuming that you all know what the scope of dental therapy is in general. You know, restorative, basic restorative, lots of prevention, and then urgent care and simple extractions. So in the CODA standards, they do have a defined scope of practice that has been written into the standards. Each state may also add or subtract certain things. If your state doesn't allow you to do something that is in the CODA standards scope of practice, it still has to be taught in order to be CODA accredited, which is interesting. You know, if your state allows for something outside of the CODA accreditation scope, then you have to teach that to the same standards that you would any of the things that have been outlined in the CODA standards. And basically, when we look at the 3 programs that have been around in the US over the years, that would be our Associate of Applied Science program at Elisabeth College. And then we have either a BA or a master's degree of dental therapy from the University of Minnesota. And another program in Minnesota Metropolitan State is a master's degree that you can achieve after you've received your hygiene degree. If you click again, we'll see one more time. Regardless of the educational requirements, those 3 programs lead to basically, with very minor differences, the same scope of practice. So we, and this is something that we see in the US in many different professions, these different levels of educational requirements from different programs. Some people call this degree creep, when we start requiring things that a lot more years of education for the same scope of practice. So we've looked at this in nursing studies, and other medical schools, dental schools, everything. And what we've seen is that professional satisfaction declines when education requirements are increased without an increase in the scope of practice. Because people learn a whole lot more than they can use eventually, once you keep adding more and more requirements to it. And those same studies also show that increased educational requirements do not lead to an improved competence of the providers coming out of those programs. And then the other issue about having more educational requirements than you might say are necessary is that it increases the cost of education, which also then decreases the diversity of the students in the programs. So having a lot more education is wonderful if there were no other barriers to things. And believe me, I went 7 years to undergrad, so I get it. Education's fun, it's great. If you've got the time and the money, go for it. But not everybody has that luxury, and increasing the educational requirements while not increasing a scope of practice, the only thing that I see that doing is creating barriers. It takes longer to get the providers out there and working, it costs more, and it makes it more difficult for underrepresented and minorities to access those educational programs. And in our state, in our tribal health system, we absolutely wanted to increase access for American Indian Alaska Native students to this program. We didn't want it to cost a lot of time, and our students are, they're part of a community back home. They can't be gone for years. We need them to go get the education, get back there and work and do a good job. And so the program we created is exactly that. And it is based on almost every other dental therapy education program around the world. Even when you're adding hygiene to it, 3 years is about the max. And historically, 2 years for just the dental therapy program has been the tradition. So, and that's been going on for over 100 years. So it's not something that we're experimenting with. This is tried and true. And we've been doing this since 2007 in Alaska, and we've had excellent results with our therapists. There's been no issues with quality of care or any lawsuits against our therapists for poor practice. So, I think we've shown that in the US, we can also do education that is appropriate length and appropriate depth, in a shorter length than a master's or bachelor's for dental therapy. All right, next slide. And this is a slide about Valerie Davidson, who is, she was the commissioner of the Alaska Department of Health and Human Services, also became the lieutenant governor for a while. And now she's the president of the Alaska Pacific University, as well as also overseeing all the health aid education programs in our tribal health system. What she's seen is that in one generation, we're changing the smiles of Alaska Native children. And this statement is so much more true than I ever would have imagined it would be by this time in our history of utilizing dental therapists. As a practicing dentist, I can go into a community and start looking in mouths, and I can see when there's been a dental therapist out there working, because there's not hardly any kids out there that don't have that have untreated decay. And we've got kids that are brushing, we've got healthy gums. We've got kids that know what causes cavities and are able to have conversations with us about it. So we are absolutely starting to see this happen, and we are able to demonstrate through studies that look at Medicaid data and such, that we have made a difference in these communities. Having a dental therapist out in rural Alaska, the more days they cover a community, the fewer cavities, the fewer extractions, fewer kids that go to the operating room, and the more prevention that's provided, which that in a nutshell is what we needed and what we wanted, and we're already getting there. Next slide, please. And these guys are why we're doing all this. Every kid deserves to have a happy, healthy smile. You know, why wouldn't you want to do that? Next slide, please. And that's it. Thank you, guys, and I'll be around for questions later.
Thank you so much, Dr. Willard. Appreciate that. All of you, to you all as attendees, please jot down your questions that you have for Dr. Willard, and we're going to circle back around once we are all done here. Okay, I'm going to transition to our next panelist, Dr. Miranda Davis. She's the Native Dental Therapy Initiative Project Director with the Northwest Portland Area Indian Health Board. In this role, Dr. Davis assists tribes in Oregon, Washington, and Idaho as they incorporate dental therapists into their clinics. Dr. Davis also provides clinical care with the Puyallup tribe in Washington State, where she has worked since 2006. Dr. Davis is passionate about public health, disease prevention, and expanding access to high-quality oral health care. She has special interest in helping patients with dental fears and in providing respectful care. Originally from California, Dr. Davis received a DDS from University of the Pacific in San Francisco and an MPH from University of Washington. Dr. Davis.
Hello, good morning and afternoon, everybody. I'm looking for the share screen button and I don't see it. Do I have permission to do that?
Yes, you should see at the bottom, Dr. Davis, but
all right, I'm good. Okay.
Oh, okay, awesome.
See my screen now?
Yes, ma'am.
Let me go to starting my slideshow. And are we still good? Everybody can see it?
Yes,
okay.
Thank you.
So, hello, here's just a quick title slide with my name and what I do and what we're doing today. So I'll introduce this presentation by letting you know where we have dental therapists in our area. So I work with Northwest Portland Area Indian Health Board, and our region has 3 states, Washington, Oregon, and Idaho. And in the winter, we don't have a lot of sunshine, and I love sunshine being from California. So I put little sunshines everywhere we have dental therapists. So we have currently 8, moving to 9 clinics with dental therapists, 12 dental therapists in our region practicing, and they were all educated at the Alaska program with Dr. Willard. So that was exciting to hear Dr. Willard talk about that. And I am happy to answer questions about any of these regions or any of these dental therapists. You can see it kind of concentrated in the top corner and we're spreading out. Here's a little introduction of our dental therapists that are working. On the top row, the second one over, is Roz Ferry, who presented to you last time. And she's doing wonderful work, as are all the others. You'll see some more pictures of all these wonderful dental therapists as they go along. And I will kind of introduce also with a slide from Community Catalyst, where I know all of you know a bit about dental therapy, but I want to tell you a bit about how I think about it and how it's working in our clinics. So in that upper left circle, we have the traditional dental team, as many people have viewed it and even maybe view it now, with a dentist, a dental assistant, and a hygienist. But when I see this, I actually think about the traditional dental team going back into the early 1900s when a hygienist was not part of that dental team. And I know that dental hygienists had quite the uphill battle becoming established with their profession. Endless legal battles, and the first dental hygienists completed their education many years before they were even allowed to practice. And now when we look at a dental team with a hygienist, we think that it makes the most sense to have a dental hygienist working, because I think many people would agree that a dental team is much more efficient and effective when we have a dental hygienist who has a specified scope of practice doing the great work that they do. And they work under the supervision of a dentist, and there is also a dental assistant working. And we can extrapolate that idea and add to the dental team with a dental therapist and a community dental health coordinator, as the dental teams in Alaska have been doing for many years with great success. So tribes in our area have seen this working really well in other countries and now in Alaska, and have decided that this needs to be the way that our tribes have the option to operate their dental clinics. And as you saw in the previous picture, we have several dental clinics operating this way. And I want to emphasize that every role on this picture has been important in those dental teams. So we've taken that traditional dental team with the dentist, dental hygienist, and dental assistant. We're keeping all those roles as equally essential as they've always been, and we're adding additional roles to that. So the dental teams where we have dental therapists working continue to have their dentists working, and in fact, working with greater job satisfaction, working at the top of their scope, continuing to have dental assistants working, continuing to have dental hygienists working, and again, able to really hone in on their scope of practice and really make the most of their work. And we've had some questions from people less familiar with our dental clinics about whether the dental therapist overlaps a lot with the dental hygienist. And I will say that both of those roles focus a lot on prevention. I don't think you can have too much focus on prevention. And the dental directors and dental teams where our dental hygienists and dental therapists are working consistently say we need both of those roles. We can't have one or the other. They've both shown to be equally essential. One neat thing about the dental therapist, and some would say also about the hygienist, is that a really good role for them is to be able to go out to work with community clinics, mobile dental clinics, school-based health clinics on prevention. One neat thing about the dental therapist going to do this outreach is that they can also do some treatment of dental decay. So when we find the disease, they have within their scope of practice some treatment of the actual dental disease, and they're able to do some work that addresses it. So I really think that that's wonderful the way it's been working. We get a lot of questions about license and certification. So what is the oversight of this provider? So there are 3 different options that I can tell you about. So there is a tribal license, a state license, and federal certification. So we'll focus on this bottom one first. The federal certification is the Community Health Aid Program, which is the way Alaska has been certifying its health providers in the within the Community Health Aid Program since 1968. And dental therapists are a provider within that Community Health Aid Program in Alaska. So they are certified by the Community Health Aid Program Certification Board. Just recently, just last year, the Indian Health Service approved nationalization of that program. So there are currently forming a national certification board and area certification boards. So our Portland area is actually very nearly ready to begin certifying its first providers through that CHAP certification board in our area. Alaska has already been doing it for many years. One neat thing about the CHAP certification boards is that they're not state specific, so they do allow for some more portability. They also are focusing on IHS and tribal sites. And some might say that this certification is even more robust than a license, because in addition to requiring CE, it also requires a number of hours of clinical oversight that's direct supervision by a dentist. So it's a very thorough and robust certification program. Other options are state licenses, which I think everybody that is a provider is familiar with state licenses and applying for, paying for, and obtaining your state license and renewing it periodically. And a tribal license is very similar to a state license, but the licensing board is tribal. In our area, we do have a couple of tribes with their own licensing boards. One of those tribes licenses providers only within their own tribe. Another one actually provides for licenses for their own tribe as well as for other tribes with legal agreements between the two tribes. And we'll move on. What does supervision look like for dental therapists? So Dr. Willard mentioned that dental therapists are supervised providers. They work under the supervision of a dentist. So the way that that supervision works is spelled out in a practice agreement. That can also be called standing orders or a practice plan. And the practice agreement, it's a written agreement. It's got to be signed and periodically updated. And it really defines what procedures the dental therapist is allowed to do within that clinic and under that supervisor, and the level of supervision that's approved for each of those procedures. So most often we find, and I believe Alaska also finds, that dental therapists work within their entire scope of practice under general supervision. But what this practice agreement spells out is whether a specific dentist, for example, wants to have a little bit more time supervising more specifically or more directly a certain procedure, or whether they, for example, want to see that a certain procedure is done only in certain facilities or that kind of thing. So it's just a way to really specify that supervision relationship between the dentist and the dental therapist. Levels of supervision that they can specify and that need to be specified are direct supervision, which in Washington State, it's called close supervision, where it's the same way that dentists are used to being supervised in dental school, where every step of the way is checked off and directly observed. Then there's indirect supervision, where you need the dentist on premises. And then there's general supervision, where the dentist can be off-site. And this is actually the most valuable form of supervision we find for access to care. This allows the dental therapist to do some of that outreach that we talked about on the previous slide, where they can go to do their work in school programs or in an off-site clinic. And this has been really key for dental therapist success in Alaska, as well as for some areas in our own region in Washington State. One of the benefits we find from dental therapists is interdepartmental collaboration and community outreach. So I would sort of classify this under recommended practices. We are finding in clinics that dental therapists are a great provider to do some of the outreach that we talked about in school programs, as well as maybe residential facilities, elders facilities, but also even within a greater clinic, going to do the outreach within pediatrics or obstetrics to really get to know patients outside the dental clinic. Some value from this is to have patients become familiar with the provider and comfortable with the provider in a different setting, and then that helps bring patients to the clinic. And it helps find some of the disease from patients that might not be thinking about going to the dentist. So these are great ways that our dental therapists have been utilizing their skills in our region. And I'll spend a few minutes telling you about the dental therapists in our region and what they're doing. In Oregon, our dental therapists are working under the authority of a pilot project, and that's a temporary situation that we hope to move to statewide legislation to allow for licensure statewide. But right now they're working in the context of a pilot project, and they're doing amazing work. So I'll tell you about these two pictures. I took these pictures less than a year ago. I love these pictures. The left side, we're gonna go back. The left side is Naomi Petrie, a dental therapist, And in this picture, she has just finished placing a full mouth of sealants on a 3-year-old girl. And you can see how that procedure went. Everybody's happy, everybody's having fun. This is pre-COVID, so she's not wearing her N95 mask. And it was just wonderful. I was there supervising that day, and I just thought it was so exciting to see this little girl having fun getting her sealants done. On the right is Marissa Gardner, and she's doing a very first checkup for this little one. And I have so much optimism for the lifelong oral health of this little girl, who is having a great experience with her mom and her dental therapist, who is from the community. Both Naomi and Marissa are members of the Confederated Tribes of Coos, Loramqua, and Siuslaw Indians. They grew up there. This is their community. They're planning to stay there for the long haul, even though there's a lot of turnover, maybe in dentists or other healthcare staff. These two are really wonderful for their community. So we'll move on and tell you about some of our others. So as many of you know, we've had this pandemic happening this year. It's been really limiting access to care for a lot of people. And our dental therapists in our region are finding ways to be innovative and still provide care for their communities. So COVID has actually really highlighted the value of dental therapists in our region. You know, when it started, we were worried, are people going to get care at all in any of these clinics? And they have continued to. So the Swinomish Clinic that I've pictured here is a great example of collaboration among team members. So it was actually the dental hygienist that thought about providing care outdoors, and she worked with the dentist and the dental therapist to set up these tents, these outdoor clinic chairs through the spring, summer, and fall. And they continued to provide care outside. They were providing non-aerosolizing procedures, a lot of minimally invasive dentistry, and a ton, all the back to school screenings. A ton of people continued to get their care in a lower risk environment. And the dental therapists here are Asia on the right and Sarah on our left over here. And you all heard from Roz during the last webinar. She's amazing, but I will also tell you that in her community, the dentist was not able to work during COVID. He was a higher risk person, and it was recommended that he not be physically in the clinic. So Roz was the dental provider, keeping their clinic open, providing all the emergency services they needed under general supervision with her supervising dentist. And she was just referring anything that was out of her scope. But she was able to continue to provide care for the community. They were so grateful. The dentist was so grateful. So that worked out wonderfully. I'm really glad she was there to provide that care. At the Lummi Tribal Health Center, we have Avina and Angela, two dental therapists working, and the Lummi Clinic did some really neat, innovative stuff with teledentistry, and they had their dental therapists bringing portable teledentistry equipment out to homes in a non-contact delivery way, with some portable equipment to allow patients to do some of their own treatment, and they kind of coach them through it on teledentistry. They're also doing work in their clinic with heightened regulations. So I love hearing their updates and what they're doing. This is Ariel, and Ariel is working in a really remote area. She's from Eastern Washington, and the clinic near where she comes from is an hour away, more than an hour away from the main clinic. And the dentist that was able to go to the clinic near her community was only able to come once a week at the most. And they were really borrowing him from the main clinic. And Ariel's goal was to use this tiny clinic that was only getting 1 day a week of dental care and expand services there. And the pandemic slowed that down just a little bit, but she didn't let it stop that goal. And they are now providing care 4 days a week at that clinic in the community where she grew up. She's able to provide care for the people she knows and loves, and that's been amazing to watch. And that's her little girl. This is a snapshot from a video she made. I'll talk about those videos. So during COVID, our dental therapists realized that people were getting a lot of their information online. So they stepped up their online presence, and they made some instructional videos. They made videos talking about dental therapy. And our team has been highlighting those videos under the hashtag hashtag Dental Therapy Thursday. So feel free to search that. You can see videos that our dental therapists have made for their communities. And I'll step back really quickly. So this is a video that Ariel made for her community, and that's her daughter looking great. And she's showing how to do a quick dental screening here. Sarah made various videos. One was about brushing. And I encourage you to watch all of them. They bring a smile to my face. So I'm going to summarize here. Gave a really brief presentation, but I would love to answer questions if you have them. So the Native Dental Therapy Initiative, our vision really is to do all the things you've been hearing about. So recruit, educate, and employ dental therapists to work in Native communities. And summarizing, we're finding that it's doing these wonderful things. It's giving Native providers the opportunity to serve Native communities, increasing employment opportunities, preventive services, treatment of disease, increasing efficiency of the clinics, increasing trauma-informed care, increasing education opportunities for patients, and we're finding, more positive oral health behaviors in the communities, as Mary mentioned, and they have greater job satisfaction. I want to point out that we're seeing that greater job satisfaction throughout the clinic. That's the dental hygienists, that's the dentists, that's the dental therapists. Everybody is able to really hone in on their specified scope of practice and work at the top of their scope. That means that dentists are able to spend more time doing complex procedures if that's what they want to be doing. And we're finding that patient satisfaction is increased also when they have providers who are happy doing what they're doing and who are able to provide this trauma-informed care. When they have providers who come from their communities, who are familiar faces, we see greater patient satisfaction. All of this with the goal for a healthier 7th generation. And that is my summary. Here is contact information for my team. We would love to hear from you and talk more about all of this. And I'm going to stop my screen share, but you're welcome to these slides if anybody would like them.
Thank you so much, Dr. Davis. That was a wonderful presentation. I love that you guys include so many pictures because it's so nice to see to see the smiling faces and to be able to put some of this to stories and to experiences. So thank you guys.
Thank you.
I know we've got quite a few questions already happening in the chat box, so you guys continue to put those in there, and we will get to those shortly. I'm going to move on to our next panelist. We've got Kim Russell, is of the Bitterwater people, born for the Tangle people. Ms. Russell is the Executive Director of the Arizona Advisory Council on Indian Healthcare, an independent state agency whose mission is to advocate for increasing access to high-quality healthcare programs for all American Indians in Arizona. During the state legislative session, Ms. Russell worked with the dental therapy stakeholders and advocates to pass the dental therapy law. She ensured that the dental therapy law included provisions that were specific to tribes and the Indian health system. Currently, Kim is engaging in the rulemaking process to provide further specifics around the dental therapy law. She has worked with tribes, tribal organizations, and the Indian Health Service and urban Indian health programs to advance their health agendas and priorities her entire career. Ms. Russell received her Bachelor of Science degree in biology and a Master's of Health Administration. Kim enjoys spending time with family and traveling. Ms. Kim Russell, take it away. Thanks for being here.
Thank you. Hi, everybody. My name is Kim Russell, and I am Navajo. I'm from the Navajo Reservation. Specifically, I'm from Chinle, Arizona, in the heart of the Navajo Reservation. I've been part of the Advisory Council on Indian Healthcare for about 7 years now. The Advisory Council is a state entity. So we're a state government agency, but we have a very unique statutory charge to do a lot of work on behalf of the American Indian community in our states, specific to health and healthcare. So we do a lot of advocacy and education. We work very closely with our state government officials as well as our tribal officials to create policies that are good for our people, specifically really trying to impact the ITU system. So thank you for inviting me to provide this presentation to you today. I would like to just kind of give you an overview of our experiences here in Arizona as we went through the very long process, and we're still in that process of, well, first of all, going through the process of passing the law, and then also the process we are currently in, which is the implementation of the law. Let me go ahead and share my screen here. Okay. Can you see my screen?
Yes, we can.
Is that in slideshow view now?
Yes.
Okay, great. Okay, we'll go ahead and start here. So some learning objectives I'd like to share with you today is to, first of all, to provide information of the ongoing process stakeholders in Arizona have undergone to pass Arizona's statewide dental therapy bill. We do have a statewide dental therapy bill, but you'll hear a little bit about some of our tribal provisions that are specific to the ITU system. I'd also like to provide insight of the various activities that tribal stakeholders engaged in before, during, and after the dental therapy bill was passed. I'd also like to provide observations that occurred throughout the process. And then lastly, provide further questions that we are considering right now. So a few highlights. I wanted to just kind of level set with you all in terms of kind of where we are at here in Arizona. So we passed our dental therapy law 2 years ago. On May 16th, our governor signed the dental therapy law, House Bill 2235. It was such a great day to have accomplished that. It was the first time that was the first time we had dropped legislation. And so our first attempt dropping legislation, we passed the law here in Arizona. A lot of hard work was put into that, and a lot of different stakeholders came together to achieve that. Another highlight, first of all, it wasn't very difficult for us to have our tribes come on board to support our dental therapy initiative. We just had overwhelmingly support from our tribes here in Arizona for dental therapy. Another highlight, which I think was really crucial to our success here in Arizona, was we were part of a greater coalition called the Dental Care for Arizona Coalition, and we had numerous stakeholders and organizations that were a part of it. Just a few that I wanted to mention. The tribes here in Arizona. We also had representation from the Intertribal Council of Arizona, who represents all the tribes here in Arizona except for Navajo. And then of course, Navajo Nation was very supportive of the efforts we did. We had also the dental hygienists. The Dental Hygienists Association was part of that coalition. And then we had a Republican think tank here, also the Goldwater Institute, that was part of that coalition. So they were all pro dental therapy. So it was, and there's others I'm not mentioning here, but it was a bigger coalition that came together to support dental therapy in our state. Another thing I wanted to mention is we were part of a kind of an overall oral health coalition, which focused on other oral health policy, so like Medicaid policy, other scope of practice bills. So we kind of already had a coalition in place prior to our efforts to move dental therapy forward. So we were already kind of had the players together. There was only opposition from organized dentistry when we went through this process. And then so currently right now, we are in the process of implementing the dental therapy law. I wanted to also provide you with a little bit of the background for Arizona. I know every state is different in regards to their timeline, their legislative timeline. But here in Arizona, the second Monday in January is the first day of our legislative session. So for this year, we just started session this Monday. And so we're busily in that, I guess, process of tracking bills and just making sure that our bills that we are sponsoring this year move forward. So the legislature usually convenes from now, January, until April, May, around that time frame. So in the April to May time frame, per statute, the session will end 100 days or before 100 days are up, unless it's extended by the chamber leadership. And they're in committee. The other months is really, they're not in committee, they're not passing bills. And then around the time frame of November, December, committees of reference convene to review what are called sunrise applications, and I'll go into that a little bit. But the one thing I do want to say about this timeline is that advocacy is conducted throughout the whole year, and reaching out to legislators before session is the best approach to ensure meeting with them. So I just wanted to provide that little bit of information in regards to passing the law. Advocacy is a continual process, even when the legislature isn't in session. So I kind of wanted to provide some of our activities and experiences and observations according to pre, during, and after we passed our dental therapy law. So pre-legislative session, and this is in the time frame between May to December. The activities we engaged in, we did a lot of outreach and education to our tribes. So we did a lot of meetings with tribal councils, meetings with tribal health committees. We also had some meetings with some of our 638 boards. Through that process, we were able to have them pass resolutions of support of dental therapy. Also in this time frame in Arizona, and I don't think this is specific for every state, but in Arizona, we have a process called the sunrise application process. And that sunrise application process, it really provides a mechanism to request regulation of health and non-health professions, or to expand the existing scope that may be in place. So for dental therapy, we were requesting to establish a new dental therapy scope of practice. A little bit about our attempts. So our first committee of reference, our first sunrise application, we submitted in November of 2016, and it did not pass committee of reference. So we didn't drop any legislation that next session in 2017. So through the next year, we got together again. And so December of 2017, we submitted another sunrise application, and that one passed. So it made it more favorable for us to drop legislation. So we dropped legislation in early 2018. And a lot of the legislation is what was reflected in the sunrise application. Some observations I wanted to share with you in regards to the before we dropped our bill. Most of our tribes in Arizona were very well aware of dental therapy. So it wasn't really a hard sell to them. I think they were also really easy to connect that with the great disparities we have within oral health care. So it was really easy to explain to them that model. We also knew that when meeting with some of the tribes and some of the 638 dental directors, we realized that some of the dental directors opposed dental therapy. We also knew that a lot of our tribal communities had some of the highest health professional shortage area scores specific to dental. And then when we would talk with them, they did request those support resolution templates, and we were able to provide those to them. I mentioned earlier that our bill was a statewide bill. And when I take a look back at our legislation in the bill that we ran, it's really kind of broken up into 5 different areas. And I wanted to just highlight just a few pieces of our bill. I think our bill is like 30 pages long. So it's a lot of, we opened up a lot of statutes. I think we opened up maybe 15 different sections of our current state law to pass our dental therapy bill. So one of the sections was just overall dental therapy regulation. And in this section, it really just prescribed minimum education requirements of a dental therapist, and also identified the practice settings where they can provide dental therapy services. It also spoke to another section in terms of licensing and renewal of a dental therapist. In our law, we had initially advocated for, I guess you could call like just like the 3-year dental therapy training like in Alaska, because we know that works, and it just makes sense for us here in Arizona, really, and of course really for our tribal people. so that we can get them into those programs and get them back into our communities. But we weren't able to have just a straight kind of dental therapy curriculum. Here in Arizona, we require a dental hygiene license to be a dental therapist licensed by the state. So we have a dual dental therapy, dual hygiene license here in Arizona. But what we were able to do in our bill was to have a provision that allowed for the ITU system to not be licensed by the state. So really what this meant, this ITU licensure exemption meant, is that if an IHS tribal or urban dental facility wanted to hire a dental therapist that wasn't licensed by the state of Arizona, they could do that. So we have that tribal provision within our dental therapy law. Another big focus area of our dental therapy bill was collaborative practice agreements. And I think Dr. Willard and Dr. Davis talked a little bit about this. It just really defines supervision and oversight by the dentist, and it also prescribed practice limits and settings. It also talked a little bit about the fees that are associated with the licensure, and it talked about, there's also a requirement, a provision within our law that requires a dental therapist study, I think 3 years after our Board of Dental Examiners begins licensing dental therapists. So moving on, in terms of the activities and our experiences during the legislative session. So this is in the area of January through May. Some of the activities that we engaged in our agency worked very closely with the tribes and Intertribal Council of Arizona to make sure that we were a part of that stakeholder process and that our provisions were considered when it came to the development of the bill language. So we met with legislators to express the support of our bill. The Advisory Council on Indian Healthcare, my members are appointed by the governor of our state. And so we have a legislative agenda every year, and that was one of our legislative priorities. So when we had meetings with our legislators, we let them know our support of the dental therapy bill. Of course, we also identified a prime sponsor. I wanted to mention a little bit about the coalition. So our coalition was really led by one of our, a lobbying group here in Arizona, Pivotal Consulting. So they did a lot of that work, that interface with our legislators. And so but they would get our input from the coalition that we were part of. So the lobbyist Pivotal Consulting, they were able to identify our prime sponsor. And here in Arizona, our sponsor was then I think she was a senator, Senator Nancy Bartow, Republican here in our state. We also made sure that we had tribal leadership who could provide testimony whenever they were being heard in committee. So we had tribal leaders from, I believe, Tana, it's about maybe 3 hours from here. We also had tribal leadership from the Navajo Nation who came in to provide testimony. In fact, our tribe, the Navajo Nation, was very supportive of the dental therapy bill, that they had one of their councilwomen fly in from Albuquerque. And we went and picked her up at the airport, brought her into the committee. She was provided, I think, like 2 to 3 minutes to provide her comments, and we sent her back to the airport, and she flew back to Albuquerque. So we're really appreciative of the Navajo leadership to make sure that they had representation. I think it was being heard in the Senate at that time to express their support of the dental therapy bill. And then, of course, as the bill was introduced, we tracked it and we signed in a support of the dental therapy bill. And we made sure to continually update our tribes as to where it was along in the process. Sometimes, because the bill was assigned to multiple committees, there was one instance where our education committee chair had a few questions about the bill. So not only was our bill heard in the health committee, it was also heard in the education committee. So she had some questions about the bill around education. So we had a meeting with the education committee chair And because we work and live here in the Phoenix area, we were able to attend that meeting. And so I think that's one of the other things that I guess an observation is if you're not near the state capitol here in Phoenix, it's kind of hard to be available for those meetings that are called like the day before. So I just wanted to mention that. And then also some of the other activities that we were a part of was just to provide data and statistics specific to our tribal communities. Some observations I wanted to share with you in regards to this process of, actually being a legislative session. The committee meetings were very lengthy. I think going back to, I want to say we had one committee meeting where we had waited for the dental therapy bill to be on the agenda. I believe it started at 9 o'clock and we sat through all the way through lunch until I think about 4 o'clock. Finally, we were done because the dental therapy bill was put at the end of the agenda. So they were really long. Again, we really appreciate the tribal leaders that were able to come out and be a part of those committee meetings. And, we know that they drive great distances to be part of that process. And I think for the most part, most of the committee meetings were hours long. And then just specific to the bill, I'd say about maybe 2 hours to 3 hours was just dedicated to our bill. There was a lot of arguments on both sides for the bill. Other observations, at least here in Arizona, when it came to providing expert testimony pro and against the bill, they were brought in from other states to provide testimony. So I think we drew from some of the other states that had already passed their state dental therapy bills. I think I want to say maybe Vermont, is that the state that was passed? But some of the other states that had already passed their dental therapy bill, we had brought in those persons to testify. And I think we also had somebody from Florida. Another observation is when we talked about our testimony, because it was a statewide bill, there was a lot of reference to other state models, to other states that had already passed their dental therapy bills. So initially, the bill it started in the Senate, but it died in the House. And of course, at the time, I wasn't a policy wonk as I am now, but they had already anticipated that the bill would die in the House. So they were already talking to a legislator to use their bill, kind of like a rider bill, or what was also called as a strike everything amendment. And so we were able to use that. We were able to use that strike everything amendment to keep the bill alive. Ultimately, through that process, we were able to pass the bill. So now I wanted to talk a little bit about the post-legislative session. So after the bill was signed, and that would be like through May, December. One of the first things that we did as tribes, bringing tribes together, is we had a tribal dental therapy forum in August of 2018. So like 3 months after the legislative session had ended. We talked about, and through that forum, we identified 5 areas where we realized we needed to concentrate our efforts in terms of implementation of the law. So one was rulemaking and licensure, Medicaid reimbursement, establishing dental therapy training programs, recruiting and retaining American Indian Alaska Native students, and then just overall planning and implementation by the ITU dental clinics. Even though we have passed the bill, the implementation process, we are still advocates throughout that implementation process. A few observations I want to provide to you in regards to what's kind of happening right now, because we already passed the law and we're in the implementation phase. Implementation of the law still requires a lot of advocacy. We are still meeting with different stakeholders to make sure that the way that the law is implemented is the way that is best fit for tribes. There's still that rulemaking process that is occurring. Other advocacy in regards to maybe changing other policy that can complement dental therapy implementation is occurring. And then making sure that resources are allocated to the implementation process. I mentioned it's a very lengthy process. When we had passed the bill, we were really excited. We had done it a first time. We had dropped the bill, our law. We passed it that first time. We were excited, and then after a while, the momentum just kind of went away because we're still in that very lengthy implementation process. So just FYI, we're trying to keep dental therapy in the spotlight here in Arizona because it doesn't just happen right away once you pass the law. There's all these other things that need to happen, like setting up the education programs, recruiting students into the program. I want to kind of end on this last slide. Just some questions that we're considering here in Arizona that we have in the background, trying to figure how does this fit into the implementation process for our tribes. So one being, how does the IHS chat factor into certifying dental therapists? Of course, IHS money has finally been appropriated to IHS to set up those boards. What does that look like for our dental therapists here in Arizona? What resources are available to our tribal colleges and universities to establish dental therapy programs? So we're really looking to HRSA a lot to see if there's resources in this area. Another thing that we've considered is, could there be regional dental therapy programs that we can establish? So instead of working with all of our tribal colleges and universities to set up dental therapy programs, and in Arizona, we have 3 tribal colleges here in our state. We have one on the Tohono Nation, San Carlos Apache tribe, and then we have the Ned College on the Navajo Nation, and they also have another, I think, technological college as well. So I guess 4 total. Instead of having all 4 of them set up a dental therapy program, which could be very costly, could one of them set one up, and that could be the educational program for the whole state? We also recognize that SIPI is wanting to develop one, and that's in Albuquerque. So could SIPI be a dental therapy hub for the tribes in this region? And then just moving forward as we implement, are there necessary amendments to the dental therapy law? And there might be. If that's the case, then we would need to go through that whole legislative process to amend the law so it makes more sense for our tribes. We're talking about that right now. So I know you'll probably get a copy of these PowerPoints, but wanted to leave you with a few of the resources. I kind of mentioned them. Our House Bill 2235. And then also I wanted to provide the resource of our Tribal Dental Therapy Forum report. I reference this report a lot as we move forward in the implementation process. And I think we're going to take questions a little bit later, but here's my contact information. And thank you for the opportunity.
Thank you so much, Kim. That was so much good information, and we learn a lot from the experiences of you all there in Arizona, and appreciate all your hard work on this effort. So thanks so much for all that good information. Okay, last and certainly not least, our last panelist for today's webinar is Dr. Michelle Dennison-Ferris. She's the Health Policy Liaison with the Oklahoma City Indian Clinic. In this capacity, she works with local, regional, state, and federal entities to improve good health policy in Indian country. Dr. Dennison completed her undergraduate training at Oklahoma State University. She earned a Master of Science in Nutrition from the University of Central Oklahoma and a doctorate in allied health from the University of Oklahoma. She's a previous awardee of the National Congress of American Indians Graduate Health Fellowship, the National Indian Health Board's Area and Regional Impact Award, and the Indian Health Services Award for Exceptional Performance for Health Promotion and Wellness. Dr. Dennison, welcome. Thank you.
Thank you, Julie. I appreciate it. Can you hear me?
Yes.
Great. I'm going to go ahead and share my screen. There we go. Okay. So I'm so excited to be here. As Julie said, I am the Health Policy Liaison at the Oklahoma City Indian Clinic. This is a fairly new position for me. I've been with them for about 12 years, but just recently was able to return to the clinic as the health policy liaison. My policy experience really comes from a couple different avenues. First, I'm a diabetes educator. I've been in the diabetes field for about 20 years and really wanted to start painting with a broader brush. And so I got into policy and advocacy here in the state of Oklahoma, most notably with the Oklahoma State Diabetes Caucus, and just moving legislation through the Oklahoma State Legislature and watching it move into regulation. Then I was awarded the Robert Wood Johnson Health Policy Fellowship, and I moved to Washington, D.C. for about a year. And I actually served out my placement within the executive branch with the Office of the Surgeon General, and got to learn what the regulation part is, especially at the federal level. And I will have to say that I certainly have a deeper passion for regulation than I do legislation. There seems to be a lot more flexibility in the interpretation of laws versus the writing of the laws. So just a brief overview of what I plan to cover today. Anytime we make policy for it to be good health policy, to be a successful health policy, you really have to demonstrate the need. So we're going to talk briefly about what the need for a dental health aid therapist in Oklahoma might be. Then we'll also briefly go over the policy process here in Oklahoma. Some of it will be very familiar to what Kim presented, as at the federal level and at the state level, our processes are very similar here in Oklahoma. Looking at licensing, what it may or may not take to get a DHAT licensed here in Oklahoma. And then of course the regulation, which is my favorite part. It's the interpretation and the implementation of the law, where I feel like you can have the best impact. I'll also briefly go over some of our previous efforts here in Oklahoma to expand the profession of dentistry, and then discuss some tips for success as we move forward with this advocacy. So, and I know most everyone on this call is very steeped in what the oral health need is here in Oklahoma. Just to briefly cover some of the things that I found as I was doing some research for this presentation was, number one, about 14% of the Oklahomans are uninsured. Now, this is broadly Oklahoma. This is not native specific, because as we'll see as we move through this proposal, this will most likely have to be a state legislative decision. And so to propose something to the Oklahoma State Legislature, it needs to benefit all Oklahomans. And so I'm looking at the state population as a whole, but also knowing that American Indians in Oklahoma especially, they have poor oral health outcomes. So as we present the Oklahoma State facts, we just know that we have an even stronger case within the American Indian community. So about 14% of Oklahomans are not insured. This is a statistic that was ran prior to the Oklahoma Medicaid expansion. This number will change this summer as we do move into the expansion part of Medicaid. 16% of Oklahomans avoid going to the doctor or the dentist due to healthcare costs. So that number is about the same as our uninsured and would be collaborated by the other statistics. So what I've heard thus far in the need and the case for DHAT in Oklahoma is that we really need to fill in the gap for access to care. So I've pulled a couple of stats for access to care. The first being from the Oklahoma Oral Health Care Report Card, and it shows that 40% of our dental needs are met in professional shortage areas. So on this report card, as you know, they graded this from A to F. A is obviously good, F is failing. So they gave us an A in this. But once you start breaking it down, if you're looking at native patients, that we are really not hitting the mark as far as having professionals out in our rural areas and our metro areas that are going to meet the need of the patient population. So here in the IHS Oklahoma City area, the dentist ratio is 1 to 3,210. And then as you just move on down in the US, general population, the dentist ratio is 1 to 1,638. So we roughly have half of what you would see in the general population nationwide on the dentist to patient ratio, which actually does speak to the need for more dental health professionals here in Oklahoma, especially in our rural counties. Special populations are always a big seller when you're making the case for new legislation and an expanded scope of practice and new health professionals. So I pulled this information for the special population. In Oklahoma, 28% of children did not have a dental visit in the last 12 months. And we got a D on this. And this actually is pretty significant considering how much our Medicaid does cover. So we are having folks that are covered for insurance to get these dental care services that are actually choosing not to access it. And the numbers just continue to grow as the children grow and they get older. And 42% of adults did not have a dental visit in the last year. When you compare that to 42% of adults did not have dental care and only 14% were not insured, you have a large amount of adults that are choosing not to get dental care who do have dental insurance. And so I do think that speaks to some of the need. Not sure what the reasoning would be behind that, but it's something that when you're looking at legislation to expand dental health care services, that certainly needs to be addressed. So in Oklahoma, there are a couple of different ways that dental health aid therapy could be achieved. There are three. I will focus mainly on the one, and that is state legislation. But as mentioned in previous presentations today and within this series, I looked back at some of those. The first one would be tribal sovereignty. There does seem to be a path there for tribes, and we have 38, I believe, here in Oklahoma that could pursue that they create their own scope of practice, their own training, their own regulations, and they enforce those within themselves as a sovereign tribe. I would expect, and I'm sure that other folks on this call can confirm this, that this is a tremendous amount of work to get to that point, and some of the other avenues to gain DHAT accessibility in the state might be more reasonable. The second road to the DHAT is the Indian Healthcare Improvement Act. And so, as mentioned with Kim a little earlier, this includes the provision for CHAP, which is the Community Health Aid Program. That is still in process. I even looked at it today. It's been very extended. There's a lot of regulation that has to be put into process to actually make this happen. But I do think that that will get there eventually. One thing of note for the CHAP and something that affects me personally in the Oklahoma City Indian Clinic, the language that was set forth for the CHAP specifically excludes urban Indian organizations. And so if you're looking at the Oklahoma City Indian Clinic or the Tulsa Indian Resource Center, we are not even, that is not even an option for us. And those are two of the largest Indian healthcare systems in the state. And so they are excluding a large portion of American Indian services just through that language. I will say as recently as October of 2020, the Office of Minority Health has contracted with an outside consultant to create a toolkit to guide tribes through the CHAP expansion. It is going to take about 2 years for this toolkit to be put in place. And so again, that just speaks to this is a very lengthy process. We are probably closer to the middle than we are to the end. And it is something that as expectations are created and you're looking at expanding the DHAT, this is something that has to be considered. It's going to be a very long process as it is with any other good health policy. So the third would be the state legislation. In Oklahoma, healthcare providers have oversight through state agencies, and that's where I will spend a lot of the time talking today. So the legislative road to dental health aid, there are pieces on how we implement it. The first would be legislation. Now, to get to legislation, somebody has to come up with an idea. And a lot of times those ideas come from your local health associations, dental board, health board, medical board. A lot of times it will have the advocacy and support there before it is poised to the legislature. However, the bill has to start there before you can create law. And so the legislation with this would have to go through the Oklahoma legislature. The licensing, if approved into law, would then need to go through our Oklahoma Dental Board, and then the regulation would go to the executive branch of the state of Oklahoma. The big player here would be the Oklahoma Healthcare Authority, which is the administrator or the body that administers our Medicaid program. Oh, backwards, sorry. So for those of you who remember the cartoon when we were kids, and it was how a bill becomes a law, and it was kind of fun, and it kind of went through all these different areas. Well, this is like real life. So how a bill becomes a law in Oklahoma truly has several steps, several points of potential failure. And as Kim was saying, you have to have the motivation and the energy to see it through, because there will be times where it will feel like the momentum has slowed, or that the interest has been lost. And so you're going to, as we build the coalition for this, you really need to maintain the momentum, the positivity, and certainly constant touch points within the Oklahoma State Legislature. So the arrows here are the things that I wanted to point out in particular. The first arrow on your upper left-hand corner, this is the idea that I talked about earlier. It comes from many sources. A lot of times it comes from your professional healthcare organizations that they want to add another profession like the DHAT. This carries a lot of weight. It carries much more weight than it would be somebody who is maybe not as professionally instilled as you would have with a dental board. The second arrow then is an author, the author, your legislator, whoever you can get to write the bill, or whoever is actually willing to sign and be the primary author of the bill, oftentimes will request an interim study. And I'm going to give you an example of an interim study. I've been involved with a couple of these with the Oklahoma State Legislature, and this is really the opportunity to prove your case. These are the stats, this is the need, this is why this particular bill or this particular piece of legislation needs to come law. Oklahoma, like many other states, is bicameral. We have the House side, we have the Senate side. And so the curvy arrow there just shows that once a bill has passed one side of the House, it then has to go to the other side of the House. As Kim mentioned in one of the early efforts, it went through one side and then it was defeated on the other, in the second side of the House, or the second side, inside of the House. So again, we just have lots of multiple failure points, but you can also turn that around and say, I have multiple opportunities to improve and to get this further down the road. Okay, so an interim study, like I said, is usually requested by a legislator. It has to be approved by the committee that it is being brought forth out of. So you could say, I'm going to request an interim study on the color of a ballpoint pen, how to brush my teeth, and how to put gas on my car. And perhaps that committee will only say you're going to get an interim study on how to brush your teeth. And so it's important that the legislator in their initial request for the interim study really almost has a sound argument so that it can get through. But it does include just the whole 360. It has health information, financial information. Financial information is very big, especially in Oklahoma with the budget crunches that we tend to experience. You need to go in with a sound financial argument for this. And then your social indicators. Everything. What is this going to affect? What does this change for the Oklahoma law if this should pass? So an example of that, So this is an example of a current interim study being reviewed in the Oklahoma State Senate. It is regarding diabetes care and cost. And I will say, because I'm a part of the diabetes caucus, we tend to get a lot of interim studies that get put forth from our committee. This is a very active group, very motivated. So we tend to have a lot of success as far as getting legislation out. But this is one of the examples that is one that is in review now. And I'm just going to scroll through this for you so you can see the extent of what the legislator is actually requesting when they're requesting an interim study. This one happens to be sponsored by the National Diabetes Volunteer Leadership Council. It has your speakers, but then you get into what are the objectives and what are our stats? And it's a very professionally supported presentation. And then of course you always end up, what are we spending? What are we saving if we should do something like this? So it is not something that you take very lightly with our interim study. And certainly if the DHAT wants to move forward in Oklahoma, it would be something that would have to be professionally presented as well. So you can see it's very stat heavy. Legislators really do want to know. Yes, they want the personal stories, trust me, but even more than that, they want to know how it's going to affect their bottom line, especially in Oklahoma. Okay. So after the interim study, and let's say that it actually goes through the House or goes through the Senate, goes through both, and it gets passed. And then you would assume that the governor would sign it into law. Once it's into law, you have to go into licensing, because the state of Oklahoma currently does not have a provision for a dental health aid therapist. Then you have to get the licensing put forth through the licensing body in Oklahoma that happens to be the Oklahoma Dental Board. That board was authorized and enacted by the Oklahoma State Dental Act. That's listed here. I will say that will take some time too, because they need to pound out the scope of work, what the education requirements would be, what the certification requirements would be. So that would take some time. Sometimes if the legislation is well written, that will be included and will give some clear guidance, but sometimes it will not. So once it gets through the Oklahoma State Dental Board, then we have to look at regulation. And I think here is where we have great opportunity if we can get the legislation to that point where it affects everybody, tribes and urban clinics and practicing dentists and normal general dental healthcare clinics here in Oklahoma. This is where we really have an opportunity to interpret the law in a way that is beneficial to everybody. I will say the implementation of law in Oklahoma does depend on a few things. So say, for example, you've got legislation, it has gone through both houses, and it is January 14th, and it passes and the governor signs it. The Oklahoma budget cycle starts in the summer. So there would not be even any opportunity to get funding until probably the following summer, because the budget cycle for this summer has already been set. The budget has already been set. And so we here in Oklahoma, we debate budget a year ahead of time. And so in April and May, you'll see the legislature start to debate what the budget will be for the following year. The budget for this year has already been set and it will act in the summer. So we would actually see if, for example, the law could pass in January and you would not have any type of budget available for implementation until the following June. So like 18 months later. That is if there's availability of funds. Here in Oklahoma, we have known laws to have passed, but there were no appropriations attached to the law. And so while the law was passed, there was no money to support it. And so during the legislative cycle, that also needs to be considered. So let's say the law passes, we're ready for budget, we have budget for part of it, and then we get into reimbursement. In talking with the Oklahoma Healthcare Authority last week, they would have to actually go in through the Centers for Medicaid and Medicare, CMS, and get approval for that new profession type, because it is not a federally approved one. They would have to go through CMS for that. They'd have to insert it in their code, write procedure, and then of course notify providers. And so the process, even at the state legislature, is not going to be a 6-month process. It's going to be an 18-month, 2-year process if you have a sound case to begin with. Also, reimbursement, not everybody's on Medicaid. Some people have Delta Dental and other private insurers. For the state, those private insurers will also have to review their policy and make sure that they are able to cover a DHAT therapy service and reimburse that back to the providers. So the DHAT is not necessarily new to Oklahoma. While I was not involved with previous efforts, I do have a little bit of knowledge on them. So 5 to 10 years ago, there was an effort to get DHAT here in Oklahoma. They had broad tribal support. The Oklahoma City Indian Clinic was involved with it at that time. There were multiple requests and proposals put toward the Oklahoma Dental Board because, as I said, when you're going to the legislature, you really have to get your stakeholders involved, and that is one of them. Those were denied repeatedly by the Oklahoma Dental Board. At that time, there was also interest from the University of Oklahoma for them to provide the training for DHAT. Now, all of that, I do understand that there's current interest coming from the University of Oklahoma, nothing formal at this point, and obviously there is tribal support. I will say that the urban clinics, at least the Oklahoma City Indian Clinic, unless we can get state legislation enacted, is kind of pulling back from it because of the CHAP does not apply to the urban Indian clinics. Okay, so for legislation, tips for success, and Kim did a fantastic job in talking us through some of the ups and downs of what she went through. But broadly, first and foremost, you have to know your statistics. Get the statistics, know them. They are seeped in your brain, because you have to be able to speak to them and you have to be able to present to them confidently to sway a legislator. Make sure they're good with statistics. Make sure that if, one report gives us an A for providing service in shortage areas, and the other one is like, we're not even half of what the national average is. Those are conflicting statistics. So you need to be able to ferret out which one is the important one for you to present, which one's the reliable one for what you're trying to do. Do a 360 scan. Make sure that you are familiar with every stakeholder, every effective process, every financial obligation or benefit that may come from your piece of legislation. Who to start with, decide who to start with. Probably in our case, it would be the dental board, the Oklahoma Dental Board. And then also recognize, and I think the others can attest to this, that when you get into the legislative process, you have a lot of competition. You're not the only one with a great idea to put into law, and legislators only have so much capacity, and they can only prioritize a certain amount of bills or concepts or laws, so that you need to know who. Everybody's going to want something. You have some competition, and know that going in. I know that when I was my time with the Surgeon General's office, we entertained a lot of folks that wanted, we want your support for this, or we want you to issue a statement on this, but you can only, spread yourself so wide. And so that is something you have to make the case that what you're doing is the most important thing that legislator can possibly do for their state. Make the case. Be prepared and transparent about obstacles. If it's going to cost $50 million, you need to tell them it's going to cost $50 million, but it's going to cost you $50 million here and save you $75 million here. Be transparent about what the weaknesses are about your proposal and conflicting statistics. Make sure you get the financial impact report in there. At the federal government, we have a CBO score that's given to each bill that comes through. That's the Congressional Budget Office. They do all the math for you and tell you it's a positive or it's a negative. I'm sure there are similar entities here in the state of Oklahoma that we could use to get similar outcomes and really make the case for a DHAP. And like I said, make it personal. Like the pictures that Dr. Davis showed, they were so cute, and everybody, I could see the chat coming up. Oh, those kids are so cute. I love the sunglasses. So those are things that really stick with you. Make it personal. Get the stories. How are we going to improve everything? But always come back to the money, because the money will be what floats the boat when you come to the end of it. So that's all I have for today. I wanted to leave some time for some questions as well, and I know the other speakers do. Julie, what more can we say today?
Thank you so much, Michelle. That was a great presentation. A lot of really good information, especially for us in Oklahoma as we kind of consider steps moving forward. So thank you. I want to thank all of our panelists that have shared their expertise today. Before we move into some questions, because I can see we have some in the chat box, I wanted to reach out to Martha Ketcher, who is joining us today. She is, you all have mentioned, or you all have heard us mention CHAP, which is the Community Health Aid Program. And as this expansion is happening into the lower 48, every IHS service area has a representative. And so Martha Ketcher is the representative for our area, which the IHS service area, which is Oklahoma, Kansas, and Texas. So I wanted to give Martha the opportunity to provide any updates on the CHAP Tribal Advisory Group and her role as the primary representative for our area. Hey, Martha.
Hi. Thank you for inviting me, Julie. I appreciate being here today and learned so much. Those presentations were really educational for me. So I just recently joined the CHAP tag I'm Martha Ketcher. I'm a member of the Cherokee Nation, or citizen of the Cherokee Nation, and I serve as a senior advisor for tribal health. As I said, I just recently joined the ChapTag, and some of the activities, more recent activities that we've been engaged in was we needed a tribal co-chair. They needed to fill some seats, and that's where I came in to fill a seat for Oklahoma. My backup is Jean from Governmental Tribal Relations, and I think the co-chair for Tribal Affairs we selected in November, and she became actively in as a tribal co-chair in December. May Jolene Begay from Navajo area. Daryl LaRoche is a federal co-chair, and Manette Galindo serves as the secretary for the ChapTag. What a wonderful team and partnership we have with the IHS, who has been really good about sharing information and culminating information for us. One of the activities that we engaged in was culminating all the comments to the tribal consultation. The IHS director recently solicited for consultation on the CHAP, $5 million on allocations of that. And that consultation closed on November the 23rd. And after that, we did a roll up and analyzed the comments from the tribes. We made recommendations to the 5 million, and it was my understanding that this was seed money for expansion to the lower 48. But what the work group pointed out was the Dear Tribal Leader letter was a national consultation, so it was totally inclusive. And so the work group recommended to allocate based on the programs that have already started at CHAP, and that was Billings, Portland, and Alaska. And this was to help them move their programs along so we would not be holding them back. Another recommendation was that 9 other areas receive an equal distribution at the area level, and what each area would do would then consult with the tribes of those 9 areas. And then another pot was for headquarters. But the headquarters pot is really to establish an infrastructure, policies and procedures, guidance and direction. And at the area level, the feedback that we got was to establish certification boards, educational platforms, whether it be with universities and so forth. But those have not been approved yet. Those were just recommendations to the agency. And we have another meeting in January, the 27th, I believe, is the date, but we'll be reconvening and hopefully have some updates on those recommendations. That's where we are so far with the ChapTag. Hope that answers any questions or gives you an idea of what we've been working on.
Yeah, thank you so much for that update, Martha. I know it kind of goes along with a lot of things that we're talking about, and I know, we're talking about CHAP expansion, that even though this, I believe, Dr. Davis, your presentation said that the nationalization happened maybe a year or so ago. So this is still very much in process, and establishing these area certification boards and all of that is still in the works. So Martha, thank you for that update, and we'll definitely be in touch with maybe after this January 27th meeting to find out more updates. So thank you for being here. Appreciate it.
Thank you for having me.
Okay, so I want to, we've got about 10 minutes left together. And so I know we've got a few questions in the chat box. And so this looks like it might be directed, this might be for you, Dr. Willard. So this comes from Lori Humphrey. Hey, Lori, good to have you on here. Thanks for joining us. So she says, after a 3-year program, the dental therapist doesn't have a degree, ? And I think that's referring to your slide that mentioned that there's not a designated degree for dental therapists. Can you clarify that for Lori?
Right. So there is, in the CODA standards, there is no requirement for a specific degree. They merely state that the program must be equivalent to 3 academic years. Our program offers an Associate of Applied Science. And we have been able to demonstrate to CODA that that is equivalent to 3 academic years, even though it's taught over 2 calendar years. And there's precedence for that with the University of the Pacific in California Dental School that is 3 years instead of 4, but it's equivalent to a 4-year degree. So we're not doing something that hasn't been done before in dental education. CODA was happy with the information that we supplied to them, that they were getting enough education to produce a competent dental therapist by the time they graduated. Hope that helps answer the question.
Okay, great. Thank you, Dr. Willard. Lori, did that answer your question?
Yes, thank you.
Okay, great. I'm gonna move on to your next question too. So, and this is a good question. So after licensure, this might be for you too, Dr. Willard, but other panelists, please step in. After licensure, can a dental therapist work outside tribal facilities?
That would depend. This is Mary Willard again. That would depend on where they're practicing and the regulations they need to follow. So in the state of Alaska, there are no state regulations allowing dental therapy practice. So our graduates who want to work in Alaska have to work in the tribal health system at this point. They can go to other states, as you've heard from Dr. Davis. They've gone down to Washington, Oregon, and Idaho to practice, and they just have to figure out how to do that with our degree and meeting the regulations in their states and tribal areas.
Thank you.
And Dr. Willard, will that change? So with CHAP expansion, will that change? So if someone was, so say a dental therapist gets licensed under the CHAP program and is certified through the CHAP certification board, they are basically certified under a federal entity and can only practice in the ITU system. Is that accurate?
Yeah, so the federal regulations trump your state laws. So if there's the federal authorization of the community health aid program is helpful in being able to have dental therapists practice without a state license and under a health aid certification. However, there is language within the Indian Healthcare Improvement Act reauthorization from, I believe it was 2012, 2010. Anyway, that language restricts dental therapy practice in tribal programs only to states where there is legislation that allows for dental therapy practice in the state. So Alaska is exempt from that because we already existed, but so in your states, you can still practice with a dental therapist under your sovereign rights. However, your ability to bill Medicaid and get paid for those services will probably be hindered if you don't have a state practice act that allows for dental therapy practice because of the language that was inserted into the Indian Healthcare Improvement Act reauthorization. Kind of a complicated thing, but yeah, it's important to have something in your state practice act, even if it's just a tribal carve out that says, you know, therapists can't practice it around the state generally, but in tribal programs, the state allows that.
Okay, thank you, Dr. Wood. That makes sense. Hence, our kind of the pathways to dental therapy, which Michelle touched on through sovereignty and then state legislation. So that makes sense. So thank you for clarifying that. And then now we have a question from Kim that's for Dr. Davis. So what's the duration of the pilot in Oregon, I believe? And will it end soon? And can you share the metrics being captured?
Sure. Hi. I'll jump back on and have this little one say hello. So in Oregon, our pilot was a 5-year pilot scheduled to end in May of 2021, but we actually were very recently granted a 1-year extension for that. And so the extensions are in 1-year increments. We're hoping we don't need more than the 1-year extension. Because we are very hopeful that the state will decide to enact statewide legislation to allow dental therapists statewide, in which case the dental therapists will be able to practice outside the context of the pilot. Right now, they're only authorized within the context of the pilot. So we got the extension in order to allow them to continue serving their communities until legislation is enacted. In terms of the metrics, we have a very detailed, lengthy, robust evaluation and monitoring plan for this project. And it's giant. There's a lot of metrics that we're measuring. And I am happy to share that. It's also, I believe it's available through the Oregon Health Authority's website. But if it's not on there, I'm happy to share that as well. So, but yes, we have many, many metrics that we're measuring with this pilot.
Awesome. Thank you for that, Dr. Davis. Okay, so I have 2:58. I have 10 more questions, but we can keep the conversation going even past our time together right now. So if you have questions that you would like to ask any of our panelists, or anything about anything that we've talked about, feel free to reach out to me or any of our panelists today, and I know they'd be happy to answer your questions. So let me type in closing. I know we've got some people waiting for CDE information, so let me share my screen really quick. Okay, so in closing, we love if you all are not already a Native Oral Health Network member, please consider joining us. We'd love to hear your perspectives. We'd love to hear from you as a subject matter expertise. We would love to hear your input on how we can continue these conversations about dental therapy and other information. So if I think Alex is going to put the link to become a member, how you can access that, and she'll put that into the chat box. And you can visit our webpage for resources information. Like I said, this is being recorded, and we'll put this recording on our webpage for you to take a look and reference back later. We also have these 3 that are listed here as well, including the 2, those are including our 2 earlier in the series. Also, you can find our data resource guide on there as well. And we want to highlight the work that you guys are doing in your community. So if you have a good story to tell, or if you have information or resources to share that we can share it with all the members, please send them our way, and we want to kind of lift you up in the work that you're doing. So again, thank you guys for your attention. We really, really appreciate it. Thank you again to all of our panelists for sharing all your expertise. So to get the 1.5 hours of CDE credit, please click the link here. Alex put that in the chat box. And after you complete the evaluation, you'll be automatically redirected to a course attendance verification that you can download for your records. If you are a tribe or a tribal serving organization, there are steps there listed to obtain credit through the IHS dental portal. And if you have any questions or run into any roadblocks with that, feel free to send me an email, and I can help kind of facilitate that process for you. Thank you guys so much for attending. be sure, take good care of yourself and each other, and we'll be in contact soon, hopefully.